Can I get a feedback؟ سامعين الصوت كويس وشايفين السكرين كويس؟
ايوه كويس كلها.
طيب. ممتاز. بسم الله نبدأ. Okay, to start with, what we're going to talk about today is a reflection of how trauma is served, and trauma has been there for a while, and still trauma is part of the training of general surgeon. It is still a field that has to be covered by general surgeon. Nevertheless, the presence of a trauma unit or a trauma system or a trauma surgeon is for the comprehensive care. A lot of input has come into trauma since this field has started, and now it's a recognized entity and training. As myself, I've been working in trauma, completely and dedicated trauma service for the last 6 or 7 years. I used to take even elective general surgery role, but now with the burden of trauma as a recognized trauma center, I just limited my work only to trauma. We will start by a simple disclaimer, because as far as I know that this is recorded and is going to be available on YouTube. So it's a mandatory disclaimer about the presentation, the material I'm going to present, and the financial disclosure. الحاجة الثانية نجي ل what we're going to talk about today. Briefly, over the coming 10 minutes, we're going to have like an appetizer about how does trauma work, and then we're going to go into a more heavy-duty discussion. What I'm going to talk about today is how a trauma system works from a bit of experience and from a reality where I work. If we went with this system to, for example, another city in Saudi Arabia like Riyadh or Jeddah, the system might vary. If we took this system to any other country, the system might vary, because the system is designed based on what you have and what's available and what's your capacity. We're going to speak about the global impact of trauma, pre-hospital approach to trauma and the trauma victim, acute care of the trauma patient, secondary care of the trauma patient, operative management of the trauma. First part of the talk, I hope it will be about 10 minutes, and we're going to talk about the global impact of trauma. The objectives of this talk is to discuss what is trauma worldwide like, the challenges and burdens, and what is the global vision in trauma care. Definition: trauma is a sudden transfer of energy caused by external force that can cause anatomical or that leads to anatomical and or physical derangement, which requires a degree of medical attention. Few other definitions علشان so as the terms are going to be, I mean, it's to be clear for you during the session. We're going to talk about isolated trauma. We're going to talk about definitions of different types of trauma. Isolated trauma is defined as injuries limited to one surgical system. We as surgeons, we divide the body into systems and regions a little bit different from other specialties. Multiple or polytrauma is injuries related to more than one surgical system that requires active management. The QR code on the right bottom side of the screen is the reference to all of this. You could actually scan it, or later on you could scan it from the lecture, and it takes you directly to the link of these definitions. When we say a major trauma, we mean a life-threatening or a limb-threatening injury that causing major structural damage, functional disruption of vital organs, potentially lead to severe permanent deformity, disability, or mortality. The key word about it, that it is to one of the vital organs. Intermediate trauma is a structural or functional disruption of a non-vital organ, potentially leading to minor deformity or disability. And finally, minor trauma refers to injuries that carries no risk of deformity, disability, loss of structure or function, and does not require hospital admission. There is a green line there. I'll continue till we find a way to delete it, because it's not something that I added to the screen. But trauma worldwide is the major health challenge of our century. Even now, with the growing challenge of COVID-19, we're still losing people per year because of trauma. Yes, the COVID-19 so far is almost reaching the same number, but the difference here is that that's something that's keep happening every year, over and over. 5.8 million of world deaths yearly. 10 million people suffer non-fatal injuries. 3,400 die on the world's road every day. 186,000 under 18 years die from motor vehicle collision annually. It is 3 times higher in developing than in developed countries. Motor vehicle collision worldwide, the annual motor vehicle collision mortality remains unacceptably high. It is still high according to WHO. The new report came in 2019, and again, it is still the leading cause of death among young group of people. 90% of fatalities occur within the first week post-trauma. Many preventable deaths occur within first few days. 7% of world's population only have comprehensive or access to comprehensive safety laws, and that applies for only 28 countries. When we say comprehensive, we're going to cover in few slides what do we mean by comprehensive. It's not only just a speeding, or it's not only a law that would allow you to drive at a certain speed limit, so it's a comprehensive law that would operate on safety on the road. Trauma mortality in relation to, again, worldwide, every 6 seconds, someone in the world dies as a result of an injury. It is 1.7 times the fatalities of HIV, tuberculosis, and malaria altogether. Worldwide, the very interesting thing about this map is that if you could see that the majority of mortality due to road traffic accident or motor vehicle collision is with the darkest green, but you could see if you follow, the second is the orange, the third is cyclist, the fourth is pedestrian, which is the lightest green. And interesting enough that safety measures still do not consider pedestrians as a risk for mortality in relation to trauma. And that's something, this is why when I said comprehensive road measures, a dedicated pedestrian access, a pedestrian traffic light, a pedestrian protected area, a flyover for crossing roads, all these are part of the comprehensive policies. And as you can see, it's almost equal. The number of people lose their lives because of being in a car or because of being walking in different parts of the world is more or less the same. This is why people normally overlook pedestrians' role in the road when they're putting laws. It is the 8th leading cause of death for people of all ages. It is number 1 cause of death for children and young adults, as I said. And road traffic accident alone is 1.35 million a year. What nobody could still measure is the trauma burden on health sectors. I didn't realize this until I started really working in a trauma unit, that when you have a polytrauma patient, you're actually having the highest number of staff in hospital involved with this patient. Take the worst case scenario of any medical emergency or medical condition. Still, you'll get more people involved in one trauma patient. You get one trauma patient, you will have the emergency services, you're going to have the emergency room staff, you're going to have the lab and the blood bank, you're going to have the radiology, you're going to have the trauma team or the general surgery, whoever you have, you're going to have thoracic, neurosurgery, orthopedics, possibly vascular as well. You're going to need OR, you're going to need ICU support, and you're going to need anesthesia if you're taking this patient to theater. And that's because of one patient, you could keep all this staff on their toes for God knows how many number of days. So no one could measure the actual burden on trauma or on the hospital staff. And this has become clear during this time of the COVID-19. And I'll just tell you why when we come to this. The demand on public life is even more. If you look just at that child there, he has to continue for the rest of his life with a prosthetic limb. The impact on himself, his family, his productivity to the community, the impact on the service and community to cater for this child until he became a productive man with a job. And this is why it's extremely difficult to measure the impact of trauma on to measure the impact of trauma on either health sector or on the community. Road traffic accident. The interesting thing now that we're coming, okay, out of all of this, what's in it for us as surgeons? 90% of the mortality due to motor vehicle collision occurs in the first week post-trauma. First few hours carries the maximum mortality, and unfortunately, most of them are preventable deaths, and we could deal with them. 23% is the overall mortality of all types of trauma. Road safety. The WHO have recognized 5, being increased to 7 road safety measures. You're not going to have a comprehensive road safety laws until you're covering all of this tightly and perfectly. They're called the key risk factors. Drink driving is number 1. Speeding. Unrestrained drivers means they're not using the seat belt. Helmets for motorbikers. Child restraint or child seats. And finally, distracted driving. Distracted driving, here comes the mobile phones, as we all know. But again, the habit of playing the music loudly and not being able to drive, the habit of being cool and showing the back of the seat so you cannot really see the distance ahead of you. All this is called distracted driving. Any change in the car capacity, modeling or so, that's again becoming against the law. So distracted driving per se became an additional factor in road safety. Based on this, WHO put a concept about trauma and trauma care, and they came with the invention of what they call the trauma chain of survival, which is basically improving chain of survival for major trauma victims, providing high quality trauma care. That's the purpose of the chain of trauma chain of survival. It is a series of actions from scene to definitive care. When effective, reduce trauma associated morbidity and mortality. Because an accident is an accident. You could do your best to prevent it, but when it occurs, you only have to deal with morbidity and mortality that could result, that could occur as a result of it. Okay, I could see another yellow line showed up but disappeared. Trauma care vision. Based on this, people start to develop the vision of making a trauma system. You need high quality trauma care on the initial service. The evidence showed that if you provided this high quality trauma care, 30% of mortalities are reduced. You need to tackle preventable fatalities within the first hour. You need to have an effective multi-specialty team approach that are capable of doing initial management and assessment. You need to develop your team with technical and non-technical skills as well. If you're asking people from different experience, different specialties, different levels and different capacities, just to gather together one morning because they're part of the trauma team and some of them don't even know each other, and then they have to operate and take very essential decision on a life-threatening condition regarding a patient, that's a bit unfair. They need to learn to play ball together. I always give the example of the last Mondial. People with single players and single heroes didn't go far. France, with a teamwork, were able to reach the final and reach the Mondial. And that's basically a group of people know how to play together and how to actually operate together. Adjustable trauma management, and that's very important. Trauma is a dynamic disease or a dynamic condition. The patient changes in a minute or two. The patient wouldn't look at you and say, the poor doctor, I wouldn't give him the pneumothorax now. I'll just give him the head injury and then I'll give him the pneumothorax later. A patient who's talking to you now, a minute later could become unconscious. A patient who's having a good bilateral entry could develop a tension pneumothorax a minute later. So it's a dynamic condition that requires a dynamic management as well. We need to tackle, as we said, the preventable fatalities. The preventable fatalities were found to be underestimation of injuries, misinterpretation of investigations, technical failures, and experienced trauma team. And this is where the input for our part as providers in the acute care should come, and this should improve. So that's the first part of the discussion about trauma. Why you really have this discussion, just to give you a vision and a concept about how trauma and trauma care and trauma concepts have developed to become now a separate entity, separate specialty. Trauma care is a global approach, not only an emergency room service. Generally, the lecture takes a long time, so I'm very keen to have pauses of 20 minutes in between. Just to recap, make sure that everyone is following. So far, if you have any input or anything you'd like to share for a couple of minutes as a break, and then we'll continue to the second part of the session, which is acute care of trauma patients. We're open for discussion or exchange of thoughts, if you'd like, for a couple of minutes.
نرحب بكل الحضور وترحيب خاص ببروفيسور سليمان حسين. You have the chance, Prof. Suleiman, if you have any comment.
السلام عليكم Professor Suleiman. If anyone else would have anything to share. We'll proceed to the next part, which is now we're going to start building the strengths of this session. It's going to get heavier at some stages. Please stop me at any stage if you feel that this is becoming confusing or you can't follow. We're going to talk about pre-hospital information, potential injuries and preparation, principles of resuscitation using the primary and secondary survey, appropriate prioritization and dynamic management, interpretation of investigations, escalation of care, responsiveness to resuscitation, and that's a very important part to you as a surgeon or as a trauma team leader, is to assess the responsiveness of your patient. And finally, endpoints in resuscitation. When would you say that this patient now is, we're going to stop the resuscitation, he's now back to his physiology, or he's not in a state of shock anymore, and what we mean by targeted resuscitation. That's a lot to achieve within about, hopefully, 40 minutes or a bit more. Again, please stop me if you feel that it's getting confusing. Pre-hospital information. What information would we like to know from the pre-hospital team? We would like to know what we call the AdMist. Would like to know the age and the gender of the patient, the time of the incident. A patient who's been trapped for half an hour or 40 minutes, you'll be surprised when they come that they are hypothermic, even in a very warm condition. We're going to see this effect with what we call the triad of death, the hypothermia, coagulopathy, and hypotension. Would like to know the mechanism of injury or what happened exactly, a pedestrian, a driver, a head-on collision, a side collision, a rolled over, restrained and unrestrained. All this would help you to kind of predict the types of injury. We would like to know, we would like to hear from them what injury is suspected. Someone who's unable to stand complaining of severe pain in the lower limbs, that's a lower limb injury. Someone who's actually being unconscious at scene, that's evidence of severe head injury. Would like to know what signs and symptoms. A patient who developed convulsions en route to hospital is something that's important for you to know. What treatment given and what is the estimated time of arrival. Patients has to be taken to the closest appropriate facility, and this has to be communicated. I think one of the major problems that facing even ourselves here in our service, and we're kind of a bit happy about how far we progress with our trauma service here, but again, the pre-hospital communication is not something that is still working effectively. The next thing is in-hospital preparation. Once you receive any type of information about a trauma patient, you need to have, as a trauma team leader or as a trauma team, or as people supposed to care of a polytrauma patient, you need to have the following steps in mind. Judgment, what's your judgment? Does this patient require a trauma team activation, or could be catered for just by a single doctor and a nurse? Excuse me. In each service, you should have what we call a criteria for trauma team activation. These are criteria in our hospital. They're very clear and very strict, and they are monitored. They check the response of people who came late, who came early. What is the impact of this? Are we still missing patients that who were supposed to have like an immediate alert all of a sudden or not? I'm still getting green lines on the screen, and I'm not sure what is the source of this. Any chance that we could delete this?
ممكن يا مستر توقف السلايد شو وترجع وتعملها تاني من جديد تقريبا من الماوس تخلي.
Hold on, أنا ما محرك الماوس لكن أوكي.
أهلا.
يعني نوقف النيو شيرنج.
ايوه يا مستر تحسي بدأت تقيل شوية.
طيب أوكي. خلينا نوقف الشيرنج ونرجع تاني. Okay, I don't want to waste time trying to delete this, but it doesn't seem to be working. Let's continue the way we are.
Okay.
Type. It's your judgment to know what kind of capacity you need with this patient initially. It's your judgment to decide the patient needs. A pregnant lady is something that would require separate setup, an elderly patient, a young child, 2 or 3 or more than one patient. So it's your judgment based on the communication from the pre-hospital team. And as I said, that's something that is still not mature enough, even with our service. And then you need to communicate this. You don't hold the information to yourself. Communicate this to the people who think are going to help you. You need to start allocating tasks to your team, to your trauma team. You need to start allocating tasks to the nursing staff. And you need to think of the necessary service. As I said, a low Glasgow Coma scale would require a neurosurgeon, but later what would the patient require immediately is a good anesthetist to intubate. What you have as well is if you have a patient with major facial injuries and compromised airway, you need to think of a surgical airway. Then at this stage, you need to be ready for it. Preparedness. You need to be prepared at all time. You need to have a trauma bed that's prepared even if the patient went into traumatic cardiac arrest. That will ease off your life. You need to have everything on the shelf available and ready. You need to be predictive. If you think that you're going to require a chest tube, get the set, it's already made. Don't open it, keep it on the side so when you need it, it's less than a minute and it's available. If you think you're going to intubate or so, again, personal protective equipment. Personal protective equipment are very important. You cannot step into a trauma without having a personal protective equipment. With these times, with the COVID-19, there are the new guidelines and new guideline adjustment from the Canadian group regarding the COVID-19 adjustments. When you're dealing with trauma, you have 2 categories of patients, a low risk and a high risk. The low risk are those who are physically stable, physiologically stable, who are controllable and cooperative, who have a normal Glasgow Coma scale, and who have a low probability of an aerosol generating medical procedures, which means you're not going to require to intubate or do a CPR or put a chest tube or even open the peritoneal cavity, because these are now classified as, or any procedure related to this is a high aerosol generating medical procedure. Then you have the high risk group. For the low risk group, as you can see, you need the standard gown, gloves, mask, hair cover, and the face shield. For high risk group who are physiologically unstable, uncontrollable, or agitated with altered level of consciousness, high probability of aerosol generating medical procedures like a chest tube, intubation, or CPR, or as I mentioned, you need to have heavier gear. Scrubs are essential because you could change them with any soiling. A tight head cover, a face shield, gloves, and a gown, an N95 mask, or you could use a full protective suit. Once the patient arrives, you need to check if the airway is clear or not. If the airway is not clear, you need a basic or advanced airway device directly. You're not going to waste time because we're going to come and talk about the importance of oxygenation in trauma patient. You need to have, you need to check if the patient is alive or not, check the pulse. If the patient has no pulse, then you're going to change to a different algorithm, which is the traumatic cardiac arrest algorithm. It's a long algorithm. It starts with a standard advanced life support and could reach even emergency room thoracotomy or clamp shield. Massive external bleeding, you cannot be talking or taking a handover while the patient is pouring blood from arterial bleed or so. This is the time where you're going to put some pressure and try to stop the bleeding, or if it is a limb, you could put a tourniquet. Expert quick look or check, you're going to look for the appearance, general behavior, or obvious injuries. The patient who's agitated, or the patient who's sleepy, or with the snoring noises. Just by the look, you know that this patient would need an immediate intervention based to this. If none of this is there as a striking finding, then you could proceed with the primary survey using the ABCD approach. And I'm sure most of you know the ABCD approach. But we're going to talk a little bit about it to make sure that we have it right in our mind, why we're doing this and when we do it. ABCD approach is for all, for children, for elderly, for pregnant, for everyone. But each group of these would have specific considerations that we're going to come to it later. You do the handover. If you can see the guy with the glasses is the trauma team leader. You shouldn't have your hands on the patient at all. You step back and you start analyzing what's happening and let everybody else take care of the patient. When you take care of the patient, it's a process. You could see the man at the head of the patient is actually holding a device in the left hand while he should actually be maintaining the head of the patient with what we call the Mills or manual inline stabilization. The right arm of the patient swinging in the air. If there is a fracture, it could hit an artery. If this patient is totally knocked down, the shoulder could become dislocated and unnoticed. So handover and receiving the patient in the trauma bay is again a technique that requires training. And any basic trauma course would tell you how to transfer the patient from one table to the other and how to log roll when needed. Upon arrival and starting the primary survey, you have in mind why you're doing the primary survey. It is to identify and treat all immediately life-threatening injuries. All immediately life-threatening. What's going to kill the patient first has to be identified and managed. Limbs are not immediate life-threatening injuries unless they are pulseless, so they became limb-threatening injuries and they jump into the primary survey. In our trauma bay, neurosurgeons and ortho would arrive. I'll say, sorry, we haven't finished the primary survey. We'll let you step in when we finish. Once we finish this primary survey, we'll allow the ortho and the neurosurgery to step in, and the thoracic as well if required. ABCD approach is the responsibility of the trauma team, who are generally either trauma surgeons or general surgery or even ER based on the setup. Primary survey, as I said, is the airway with the consideration of the C-spine. It's breathing and ventilation, assessing the breathing and ventilation and assessing any thoracic injuries at the same time. Is assessing this, the C is for assessment of the circulation. And that's now a lot of science and a lot of work comes under C. The disability is when you do the mini neurological assessment, checking the neurological function of the patient, and the exposure is to really check for any external or obvious or missed injuries that actually could jeopardize or become a life-threatening problem during the time of resuscitation. We're going to proceed to the airway, and with the airway, the initial approach, you're going to put an oxygen mask with a reservoir. You're going to do a jaw thrust. We don't do chin lift, head tilt, as I said, because of the protection of the C-spine. And if there is any gurgling or any secretions or any fluids in the oral cavity, immediately have to do suction with this. And then you need to assess the need for an oropharyngeal airway. The moment you release the jaw thrust, the patient again goes snoring. So then you need to use an oropharyngeal or a nasopharyngeal. And well, I think we all know the difference. A nasopharyngeal is for a conscious patient, but it still cannot maintain the airway. And an oropharyngeal is for an unconscious patient who cannot maintain the airway. If all of this is not working and you think you're unable to give adequate ventilation to this patient based on the saturation and based on the respiratory rate, you could go even far to bag mask ventilation, the BMV, and there are techniques to do this, and any standard trauma course will teach you this. And then if the patient at that stage is still you're unable to ventilate this patient well, you could go to insertion of a supraglottic airway or supraglottic device and advanced airway management, including supraglottic device. All these are standard information that each and every one of you, once you go to a standard trauma course, you'll learn about it. We're going to talk more about decisions and the science behind this. And it's now a standard adjunct to primary survey is to put an esogastric tube or an orogastric tube to deflate the stomach and to drain it. And if you're managing the airway, normally the airway person could slide the tube if it is safe enough to slide the tube without oral injuries. You should always keep the C-spine immobilization until you follow a standard system to clear it. And there are systems for this, like the Nexus, for example, the Nexus system. But there are things that make you highly suspicious of a C-spine injury, like a multi-system trauma, a patient who's unconscious with multiple injury. You're not going to remove the C-spine immobilization until this patient is awake and you're actually clinically able to examine the patient. Altered level of consciousness and blunt injury above the clavicle because of the deceleration movement. When would you start considering that this airway is difficult? If the patient, even with maintaining the head position, maintaining the jaw thrust, you're still unable to maintain an open airway, then that's a potential difficulty in the airway. People with spondylosis, with cervical spondylosis, people with short necks who could not actually have a proper airway, children with their head leaning forward, actually these are all potential difficult airways. Foreign body in the airway that you cannot retrieve, secretions, blood and vomiting continuously happening, that's a continuous hazard to the airway. Laryngospasm. Laryngospasm, there's a lot of work is being done about laryngospasm and approaching the airway without giving a muscle relaxant. Laryngospasm could be very severe, could be fatal. I think with your experience, you've seen it when there is premature extubation for an elective patient by the anesthetist. I think you came across this few times in theater maybe. The patient goes into laryngospasm, the patient cannot breathe, and re-intubating this patient again is really a nightmare. Airway edema, as in burn patient, as in pregnant ladies, that would all minimize the clear access to the airway and the airway manipulation. Technical problems, as whatever device you're using is not working with you well, or your capacity, your experience, or disruption of the anatomical structures. Sometimes you get a patient with very severe facial injuries like this, but they're still maintaining an airway. And although it looks severe at the beginning, monitoring this airway, that's a potential airway now, but just with simple fixation of the cuts, you could see that the patient is able to maintain an airway. So it's your judgment. And I'm not sure if it is fortunate or unfortunately, most of the decisions we're going to make regarding our trauma patient based a lot on your judgment and your training and your capacity. Now we're going to go to infraglottic airway. You'll need to secure an infraglottic airway, which means an airway below the glottis that's approaching directly the cricopharyngeal area or approaching directly the trachea. You will need to consider this immediately if the patient is in a state of apnea. If the patient is hypoxemic from the start with PO2 of less than 60 millimeter mercury in a spire of 15 liters of oxygen, if the patient is returning carbon dioxide in a worrying way like a PCO2 of 50 millimeter mercury or more, if the patient is showing evidence of severe head injury as calculated by Glasgow scale of 9 or less, and of less than 9, and if there is any airway injury, like a laryngeal injury or a tracheobronchial injury, the man we show his face, he only has facial injuries, but actually his oral cavity, his larynx and his trachea were intact. This is why such patient, although it looks worrying at the beginning, but he's able to maintain an airway. Yet you should consider him a potential difficult airway until you're secure and you're happy and you've observed him and you assess the airway properly. An urgent airway is required if the patient is agitated, if the patient is having high risk of aspiration, like, for example, a low-fort fracture or a fractured base of skull with continuous bleeding into the mouth. If the patient is unstable, having an unstable mid-face trauma, as I said, if the patient having a penetrating facial or neck injuries, or if the patient having a large flail segment, because these patients are going to become exhausted. And I think you all know that a flail chest is not treated by a chest tube, but it's actually treated by supporting the ventilation of the patient, because they lose the ventilation effort. They lose the chest capacity to create the negative pressure and the ventilation effort. Again, for humanitarian reasons, if this patient requiring continuous intracranial monitoring, if the patient is having a comorbidity, there are certain circumstances that could be considered as well for intubation or for securing an airway. Overall, that's a standard approach now to the airway. Again, it's an ABCD. It's a standard algorithm called the vortex algorithm for airway. The green outer line is the safe zone. And then while things start becoming complicated, as it's a conical, it gets tighter and you escalate your management. From the green line, when the patient is ventilated well, you start to getting airway difficulty or anticipate airway difficulty or anticipate that this patient would need a more advanced airway management, as you can see. Then you could go directly for intubation. Now, if that is becoming difficult or you don't have the experience, you go for what we call supraglottic airway device like the LMA. And if both of them are failed or you don't have the experience for either, you could go just for bag mask ventilation until you get someone to help. And there are patients who you cannot intubate and you cannot oxygenate at all. And then these are the patients that they will need a surgical airway through the front of the neck. Some of you would say, okay, well, we're surgeons. Why do we need to know this? Because you're the trauma team leader there. You're the one who's supposed to monitor this. You're the one who's going to admit this patient under your name. You're not going to let people from ER or here or there start playing and making haphazard options about your patient. Airway management is essential. By evidence, airway management is associated with consequences that we'll come and discuss it. Now, when we look at the level of evidence about how could we intubate a patient, you have to use medication. Medication make the intubation successful from the first attempt. The more you attempt intubation, the more there are periods of hypoxia. Remember that you're intubating the patient not to prove that you can intubate. You're intubating the patient because that patient needs oxygen into his circulation. And the longer you try and the longer you struggle, like sometimes we see with our colleagues from ER or anesthesia, the longer this patient becomes hypoxic. So it's not about I could actually intubate or not. It's about I could deliver this oxygen to the circulation. The evidence, which is a level 1 evidence that without medication, you're going to go for a first and a second and a third attempt. And even with the third attempt, it's as good as 73% chance. When you give sedation only without a muscle relaxant, that's the important part, then it only goes to 75%, as if like you haven't given anything. And that's interesting because people think that when you give sedation, the patient will tolerate the tube. Put the finger in your throat, and if you could tolerate the finger in your throat without vomiting or heaving, this patient could tolerate it. A knockdown patient with a low Glasgow Coma Scale doesn't mean that he doesn't have that his GOG reflex is not functioning. This is why you have to follow a complete rapid sequence intubation or a muscle relaxant, a paralytic agent, and a sedative at the same time. The three of them have to work. When you do this, you have 81% chance of getting the tube, even in a difficult airway, from the second attempt, and 91% chance. So your role as a team leader, if one attempted the intubation and failed the first time, you know he's not the expert in the field. Okay, thank you very much. Try to put an LMA. You can't start bag ventilating this patient. Don't do a second attempt. Leave the second attempt to someone who's more experienced. Because every time you attempt, it's actually, as we all know, it's actually hazardous and harmful to the trachea. Now, the evidence of 2 attempts or more, it's very interesting when we look at the complications here. The complication rate increases completely, or the adverse outcome increases completely with the second and the third attempt going onwards. Even at least one advert event, and that's the top blue line. The second one is the red line, desaturation, and that's a huge problem. If your patient is desaturating, then all what you're doing is pointless. You're intubating to secure oxygen, not to prove that you can intubate. This desaturation decreases over and over in a patient who's already hypotensive, who's already hypoxic, so you're totally depriving this patient's brain from oxygen for God knows how long, and then this patient will end up with brain edema, that's the least. So if you have first and a third attempt and you're unable to get the airway correctly, then you have to be prepared that you're giving this patient neurological complications. Esophageal intubation is still in the best hands. It still has a higher and higher incidence. And that's funny enough. So again, this evidence shows that first attempt, second attempt by the most experienced person available. In between, there are measures. There is evidence that video laryngoscope or glidoscope are very useful to get the airway from the first attempt. So these are devices that should be made available for less trained or even for well-trained people, but in trauma facing a difficult airway. These devices has to be available. Training on these devices is very simple. It's not very difficult. There are specialized courses now for airway management. And then we go to surgical airway. People don't go for needle cricothyroidotomy anymore. It's not the choice now. You could go for surgical airway, the top left side, the same like we do tracheostomy. That takes a longer time again. There is a risk of bleeding and a lot of hazards. Or you could go for the phone at the front of neck axis, which is the surgical cricothyroidotomy. It's just a longitudinal slit or incision on the cricothyroid membrane. And once you put the scalpel, you turn it 90 degrees, that's going to do a stretch, and you use a size 3 or 2.5 endotracheal tube on a bougie, and you slide it in the trachea, and that works well, and that's now becoming the standard of training in trauma care for basic trauma courses. So in conclusion, airway management and securing oxygen is with evidence confirmed to have reduced mortality, restore internal milieu faster. People actually tend to be extubated faster if they have their airway secured earlier. Back again is the concept that we always thought that a trauma patient, if intubated tiny, God knows when we're going to be able to extubate it. That's actually the evidence have reversed this and improved neurological outcome, and that's very essential. The most common long-term disability of trauma patients is neurological. So that's so far about the airway management, and we're going to move to breathing. I could have a pause here of a couple of minutes. If anyone would like to share any ideas, or even if you'd like to stretch for a minute or so, because talking over and over, non-stoppingly, actually, you'll tend to have people getting numb or not following. So anyone would like to share any thoughts, any experience? What of this you're comfortable to practice? I'm sure all of you came across trauma patients. What of this are you comfortable to practice? What of this you've seen in your trauma patients? Are you all following?
Yes, for sure.
Right. We move on to breathing. Breathing or assessment of the chest, actually, it is for two things. Number one, eliminate any immediate, to support the breathing, and number two, to eliminate any immediate life-threatening thoracic conditions. There are immediate life-threatening thoracic conditions that could kill the patient even during the primary survey, and this has to be eliminated. One of these conditions are flail chest, open chest wound, massive hemothorax, tension pneumothorax, cardiac tamponade, laryngotracheal injury. So unless these injuries are kept in mind and looked for during the primary survey, you could lose the patient. Flail chest is obvious clinically. The bigger the segment, the less the saturation, the more distress the patient, the more that this patient would require intubation and ventilation. Open chest wound, that's a simple pneumothorax waiting to turn to attention pneumothorax at any stage. A massive hemothorax could actually compromise the breathing by a pressure effect and could actually result in hypovolemic shock. Attention pneumothorax, I think most of you know how to assess it and diagnose it clinically and how to manage it. Cardiac tamponade, again, it's the same triad like tension pneumothorax with the difference that here there is muffled heart sounds, and in the other one there is decreased air entry with hyperresonance. And then laryngotracheal injury, if it is massive, you could see it with surgical emphysema, subcutaneous surgical emphysema, and sometimes you could see that the voice is, it has a very specific voice or a very specific noise as a stridor when you are assessing the patient. By all means, I'm going to talk very briefly about tension pneumothorax because, again, that's one of the most common things that you come across. You just need to understand that in a noisy emergency department, the best way or the best approach to clinically diagnose a pneumothorax, a tension pneumothorax, is by looking for symptoms of chest pain, dyspnea, and auscultation. That's by evidence. Chest pain and dyspnea alone without auscultation has a 40% chance of diagnosing this. Chest pain alone has, relying on chest pain alone, it has only 2% chance. So you have to meticulously listen, assess dyspnea, and check for chest pain or check tightness. What do? We used to do a needle decompression. The evidence have grown that it has only up to 53% success rate. Mainly, it is actually a very short time treatment. It depends on your tactile maneuver, the same like the ultrasound. It really takes a good amount of training to be able to reach the pleural cavity and not properly. And finally, you can only try it once, because if you try it again, you've actually created a communication. Problems, normally the needle is short. People, in obese people, you cannot reach the thoracic cavity. It could actually go into a wrong puncture site. It could go into the internal mammary if you didn't go in right. It could become dislocated, kinked, or obstructed. Now, this is why for people moved with the training within the last 4 or 5 years to what we call a thoracostomy access, which is basically you make the incision like you're going to put a chest tube, but you just insert your finger and relieve the tension. Now it's a simple pneumothorax. By the time they get the chest tube, you only have one access. Again, now they've developed a special decompression needle. And if you have the special decompression needle, the evidence showed now that it is better as a choice for relieving tension pneumothorax as compared to the thoracostomy tube. Circulation, initial assessment. You need to assess the hemodynamic status of the patient, standard assessment, blood pressure, pulse, capillary refill. We know all where we look for the pulse, and we're looking for a blood pressure. We're looking mainly for the systolic blood pressure, and we're going to come and talk about what acceptable systolic blood pressure. And then ischemic overt hemorrhage. If you found the wound like this, an entry wound for a gunshot, make sure you cover it. If there is a streak of blood, you could underestimate this streak of blood, but actually, when you check this patient, you'll find it's more than a streak of blood. And when you look at the resuscitation room after the patient leaves the room, you realize that this patient actually was losing a lot of blood, and we just have the tendency to underestimate this. Remember, it's only 5 liters. And it's just to make it clear for you, 5 liters is not a large amount. 5 liters of blood in your circulation is not a large amount. And you could easily lose half of this amount slowly and that's been underestimated. If we think that bleeding could occur, or if we think that when we're assessing the circulation, hello?
Yes, continue, sir.
Okay, if we think that assessing the circulation, we're assessing the circulation of shock, I think you all know now that for the last few years, people have moved from the definition of shock as inadequate tissue perfusion to actually inadequate tissue oxygenation. You're correcting the circulation to secure adequate oxygen to vital organs. tissue oxygenation is compromised in the 5 components of the assessment. It's compromised in the airway, it's compromised in the breathing, okay, and it's actually, or in the thoracic injury, and it's actually as well compromised in the circulation if the patient is having bleeding and hypotension. It is compromised as well with head injury, and it is compromised as well even with dismantled limb. So tissue oxygenation involves every part, and decreased tissue oxygenation has to be corrected. So we have to deal with shock and circulation as impaired tissue oxygenation. We're resuscitating and maintaining a volume that could actually provide adequate tissue oxygenation. You have a trauma patient, you look at the vitals, a systolic of 94, and you look at the saturation of 93 and say, hey, well, that patient is okay. I'll give him some fluid and he'll be fine. You look at the vitals they picked up and some oxygen and all good. But actually the evidence has started to show that this is not enough for adequate tissue oxygenation. The evidence showed that people in pre-hospital, about 35% of people in pre-hospital would die from bleeding. More or less the same amount would die in the first 24 hours, but actually very few would die after 24 hours. And people with CNS have a constant high mortality. And when they were looking at this, okay, we give volume, why is this not improved? Because with time, we started to realize that we're not giving the correct volume, we're not giving the correct medication, we're not giving the correct fluid. So we're going to come to the fluid, but let's continue to know if our patient, our trauma patient, is in hypovolemic shock or not. FAST scan is very important. It comes during the circulation assessment. You check for a collapse inferior vena cava, you check the 5 parts, looking for hepatic or splenic or pelvic hematoma. You check for myocardial contractility if the patient is hypotensive or if even the patient is going to traumatic cardiac arrest. You're not going to stop the resuscitation unless you have a confirmation with ultrasound or with FAST scan that there is no contractility on the heart. Again, you could do an ultra-guided central venous cannulation based on the experience, but again, IO is the line of choice for everyone who's not as trained enough to go for a central line. Then when we look at the blood pressure and we assess the patient, we say, okay, well, we have 4 classes of shock. They became 5, but let's still operate with 4 classes. Class 1, we only give crystalloid, and class 2. Why? Because the blood pressure is still maintained. And only when the blood pressure starts to drop, then we start to think of giving crystalloid plus blood. While as a matter of fact, this patient is in a state of shock from the start, just given the heart rate. But we haven't had this perception in our mind. We wait until the patient loses 30 or 40% of their circulation, 1,500 to 2 liters, before we start giving blood. And then we lose patients after a few days, or they end up with permanent brain damage because they haven't had enough oxygen. Crystalloid does not carry oxygen to the vital tissues. And that's one of the things, the concepts that have changed enormously now in literature. Trauma patient receives 1 liter and you directly proceed to blood. You're not going to continue filling patient with fluid, and there is no role for colloids. Overall, the management of shock goes in different aspects, and it's not only one aspect. You need to control the external bleeding, and you need to look for any non-hemorrhagic causes of shock, and we'll come and talk about this very shortly. But you need to identify the source of bleeding, because it's a combination of restoring the oxygenation and stopping the bleeding. And again, you need to have a secure access. You need to keep an eye on the coagulation, derangement, and as well, you need to consider giving tranexamic acid. And the evidence now for the last 2 years that tranexamic acid is a standard treatment within the first 6 hours of trauma for any patient who's showing evidence of inadequate tissue perfusion or oxygenation. And how would we know this? We'll come and talk about it. Trauma patient could develop any one of these shocks. Now we have the tools to diagnose hypovolemic shock, as I said, with the help of the ultrasound, the FAST, but as well, trauma patient could have cardiogenic shock. They could have obstructive shock in case of tension pneumothorax and pneumopericardium. And as well, they could have a distributional shock in case of neurogenic or more commonly spinal shock. So they could have any type of shock. And here with the last one specifically, the old concept that you're not going to treat a shock trauma patient with inotropes is not 100% correct now. Now we use inotropes or we use vasopressors in a very controlled states when we're dealing with trauma patient. If I'm taking this patient to theater to stop the bleeding, we're kind of reduce the amount of blood given to the patient. We could rely on vasopressor for a short time until I control the bleeding so the patient could make use of this. If the patient having a distributional shock, no matter how much you fill him with volume, unless you give him vasopressor, it's not gonna work. So yes, there is now a window for this. And that's again something that's to be assessed based on the patient condition. Massive hemorrhage. When would you think that this patient might have a massive hemorrhage? If the patient has a drop of in hemoglobin, but we're not going to wait for this. If the patient has a low basic CES, and that's becoming very essential, and we're going to talk about this evidence very shortly. If the patient showing evidence of acidosis, I mean, or wide basic CES, or a minus, or as we call it, a base deficit. Or if the patient having a low systolic blood pressure, if the patient is tachycardic, if the patient having evidence of intraperitoneal or intra-abdominal fluid, and all of this after giving 1 liter. You give 1 liter to the patient, and you should see a response in his vitals. If you're not seeing a response, this patient needs more. Simple. If the patient needs more, then this more is going to be blood and not more fluid. So that patient is having a severe hemorrhage no matter what the situation is. And this is what we call them the partial responders. Because when you have a trauma patient and you assess the hemodynamic status, I should have mentioned this with the grading of shock. You have 3 categories of patients. You have the patient who's stable all through. You have the patient who's unstable all through. These are the easiest 2, but the challenging one is the one in the middle, who's actually a partial responder. And unless you give 1 liter of fluid, you cannot say that this patient is actually stable or unstable, responding or not. But once you give 1 liter of fluid, be prepared to move to blood. That's a sign of severe hemorrhage. Another predictive part is the presence of penetrating trauma, a systolic pressure persistently less than 90 or less than 90 from the start, a heart rate of 120 from the start. That's a patient who's having severe hemorrhage no matter what other things tell you. Or if he has a positive fast scan, and a positive fast scan is the one that's showing moderate to large amount of intraperitoneal free fluid. Any 2 of the above would require the initiation of what we call the massive transfusion protocol. Circulation volume management. Okay, we spoke about volume and what do we give, and there's a lot of evidence. Very briefly, we're just going to go through some of the evidence I picked. The evidence about managing shock in the trauma patient is huge. And we're going to speak here, I selected few evidence or publications that's going to build our understanding to this. And this has been going for a while. This is actually about 20 years ago, when people realized that hemorrhagic shock, which means by definition a systolic blood pressure of 90 or less than 90, is a predictive sign of mortality. Okay, so yes, we know that people could compensate, but we know that when their systolic pressure drops to less than 90, that's a very poor prognostic sign. They've lost at least 2 liters of their blood, 1.5 to 2 liters. And these people, if they haven't received the appropriate resuscitation, they cannot actually pull through very easily. Increasing volume of crystalloid in the first 24 hours was strongly associated with increased mortality. Very strong correlation, and this evidence has come in 2002. And again, around the same time, 20 years ago, people found that targeting systolic blood pressure, heart rate, and urine output would leave up to 50 to 85% in some series of trauma patients in a compensated shock. They are still in shock, but they're compensating. So we're exhausting their body. When they fall, they really fall, and you can't pull them through. What was their evidence? In spite of these findings, they started to look at the parameters of shock, which is inadequate tissue perfusion or inadequate tissue oxygenation. They found that there is an increase in lactic acid, and there is a decrease in the in the venous or the exchange oxygen level, or the venous, the mixed blood oxygen level, which tells you that these cells are hungry for oxygen. They're actually taking as much oxygen from the circulation as they could. These are very sensitive parameters. The same parallel evidence afterwards started to look at lactic acid progress in trauma patients. Decrease in lactic acid is associated with increase in lactic acid associated with decrease in survival in 2004. And the buildup continued as well in 2006, that the persistent decreased base deficit is associated as well with increased mortality. So now we know that there are a lot of factors working behind the volume replacement. A volume replacement is not going to save this patient, and it's the tissue oxygenation should be the target. Okay, now when we look at the severity of injury and the coagulopathy, we found that when the patient we all know that with the injury severity score, any injury more than 6 is actually, any injury more than 4 is actually a severe injury. So it means that you could see the mortality is increasing with the increase in the coagulopathy. So if the patient having a coagulopathy, the mortality increase regardless even of the severity of injury. And again, so it is not only volume, but it's actually acidosis and it's actually coagulopathy. Why would a trauma patient develop a coagulopathy? They're hypothermic, they become acidotic, and we've proven this. We're giving them only fluid, which is going to impair the clotting factor. We're giving them RBCs that's not active or functioning. And we're actually deranging the clotting factor sometimes by deciding to give this factor or that factor, or only platelets. Not to mention the tissue injury and the demand on oxygen and tissue damage. All this would lead to coagulopathy, or what they call it, trauma-induced coagulopathy, TIC, and that's now a very recognized concept in trauma management. So knowing all of this in circulation, when you find the patient with one of the things that we mentioned, as we said, any increase in the heart rate, any poor response after the first liter of fluid, any evidence of massive hemorrhage or massive bleeding, you need to consider activating what we call the massive transfusion protocol. And there is a lot of work about the massive transfusion protocol, which is a way of coordinating the care of patients requiring massive transfusion. It is to facilitate communication between different facilities, nursing, transfusion, laboratory, clinical care, to give blood products. There is, basically, you're not going to give fluid, you're going to give products, you're going to give blood, you're going to give platelets, and you're going to give factors. The three of them has to go together. And the funny thing is that there's a lot of work about whether you give three, it's the 2-1-1 protocol for those who've read about it, or it's the 1-1-1. And there is no strong evidence to say there is any advantage of giving a 2-1-1. So people now stuck to 1-1-1. Which means 1 pool of platelets, 1 pool of fresh frozen plasma, and 1 unit of RBCs. And you keep doubling this based on the need. But again, over the last 4 years, this is more or less becoming obsolete, and people now starting to work on what we call the targeted therapy. We'll come to this. If you have a patient with a trauma patient, ask yourself, hemostasis, resolution, and coagulopathy, yes or no? If there is evidence of coagulopathy, if the patient reached a hemostasis with no evidence of coagulopathy, then stop the massive transfusion policy and just give only blood as needed. If not, then rely on the lab to tell you the findings. And again, if there is any ongoing bleeding, keep in mind that this ongoing bleeding will continue exhausting your patient. This is why for my trauma patient, I check next day not only the hemoglobin, but the platelets. For those who have a concealed hematoma, the daily hemoglobin level and the platelets tell you if this patient is still trickling or consuming his factors or not. I spoke a minute ago about targeted resuscitation. What do we mean by targeted resuscitation? Again, we're not going to exhaust the lab. And okay, we agreed that we're not going to give crystalloid. We agreed that after 1 liter, if there is still evidence of no brisk response or normalization, or there is anything to suggest a massive hemorrhage, then we're going to escalate this to a massive transfusion protocol. The massive transfusion protocol, instead of requesting a unit of blood and a pool of platelets of 4 and a pool of fresh frozen of 4 to 6 based on your policy, you're going to go for a target resuscitation. The short-term coagulation, you're immediately going to take a blood sample. You are looking for a 24% increase in the hematocrit for platelets more than 50,000 or more than 100,000 for CNS injury or multiple higher injury, for fibrinogen more than 100, for APTT of less than 45. This is what you're going to look at once you've given the initial therapy and you request a repeat of blood sample within 2 or 3 hours. The long term, that's for 24 hours, you're looking for 24% of the hematocrit, platelets more than 100, fibrinogen more than 150. If you have a good ICU support, they'll look after this for you. But you need to be targeting, you need to understand this, because you'll get a patient with a compound fracture, and the orthopedics after 6 hours want to take him to theater. If that patient lactic acid is not corrected, if that patient is still having evidence of coagulopathy, you cannot permit or allow them to take him to theater, because he's going to come back in a worse condition, could fall in the triad of the lethal triad. So these are your targets with the ICU to give clearance for other specialty to go for non-life-threatening injuries, for example. And again, it falls back on you if you're the primary physician taking care of this patient. What is your aim? Systolic blood pressure of 90 to 100, mean art of 60 millimeter mercury. That's your aim if you'd like to look at the monitor every few hours and check where we're standing. You're aiming for a lactic acid correction. There is what we call lactic acid clearance rate. You need by 6 hours to maximum 24 hours to correct the lactic acid back to normal based on your control. Anything less than 1 or 1.5 is acceptable, and you could give clearance even for surgery, because lactic acid is a true reflection of tissue oxygenation. When cells are hungry and suffering, they use anaerobic glycolysis and they produce lactic acid. When cells having enough oxygen, they don't produce lactic acid, but you still have some lactic acid in the circulation that's going to cause acidosis, and you need to clear this. So the concept is not only to restore tissue oxygenation, but to restore normal physiology. Why is this? Because our bodies are designed to heal. You have a cut, it will heal. You need to restore the normal physiology of your body so your body could start healing. Another thing I would like to mention in the circulation is the pelvic assessment. Any clinical or radiological evidence of pelvic disruption, it means that you clinically assess the pelvis, or you looked at an X-ray and there is evidence of pelvic disruption in the presence of hemodynamic instability, would require directly the management of pelvis for the sake of stopping the bleeding, not for the sake of actually fixing the pelvis. How do you do this? Bed sheet or standard pelvic binder. Then there is operative management. Operative management is not the scope of our discussion today. Operative management of bleeding, of contamination, of solid organ, of liver, of kidneys, of pelvis is out of the scope of our lecture for today. Today, we're only talking about the acute care, not about when you need to take this patient to theater, what to do. In the D, you're going to do the mini neurological assessment. You're going to take the Glasgow Coma scale in the pupils. Remember that we check both sides and we take the best response. If the patient showing abnormal flexion on one side and abnormal extension on the other side, you take the flexion because that's the best response. The evidence about traumatic brain injury, as you can see, you should always maintain the systolic blood pressure more than 90. This could represent a challenge when you have to run a permissive resuscitation for patients like patients with dissecting aorta, for example, or for patients who are showing evidence of concealed hematoma like a pelvic or retroperitoneal or encysted hematoma of the spleen or the liver. These people, you're not keen to run the blood pressure, the systolic blood pressure high. You use what we call permissive resuscitation, but again, you need a good systolic blood pressure of actually 100 and above to maintain the brain oxygenation. So that's normally a delicate balance. And if we are going to talk about management, at this stage, you will have a lower threshold for intervention to stop the bleeding if the patient having an evidence of severe head injury. I already discussed the second point. The arterial oxygen saturation should not be below 90% by all means, because remember this, the brain vessels are like the kidney. They rely only on the dissolved oxygen, not the oxygen carried in the RBCs. Level of consciousness and pupils and Glasgow scale shall be examined continuously and regularly. You'll be surprised with a patient who's been talking to you and then in 6 hours, you actually lose him. We unfortunately lost the patient after 24 hours because of an intimal tear of the vertebral artery that wasn't shown on the initial CT scan because it wasn't a CT angio. The patient developed occipital fossa edema and he coned within 2 hours. The CT angio was done after that, and we found that he has an intimal tear of the vertebral artery due to acceleration deceleration injury that wasn't obvious during the pan CT at the trauma time. So close assessment of this patient is essential. Hyperventilation, hypertonic saline, and mannitol. There is a lot of work about it. In conclusion, remember the drive is the carbon dioxide. The recommendation now is PCO2-driven oxygen ventilation and not oxygen-driven ventilation. You're looking at a PCO2 of 33 to 35 to 37. This is the range where you need to keep your PCO2 to avoid brain hypoxia and brain edema that could result in adverse effects. We come to exposure. Exposure, remember, you remove all the clothes, you examine entire patient, you prevent hypothermia, and you remove the spinal board according to criteria when indicated. Couple of lines about spinal precautions. Any unconscious patient should have the spinal precaution available. The cervical spine shall be immobilized before even removing the patient with the pre-hospital team, before removing the patient from the scene. In conclusion, primary survey, patient arrives, you assess for any signs of life, or if the patient is having traumatic cardiac arrest, you follow the traumatic cardiac arrest algorithm. You work the airway, the breathing, the circulation, you do the immunoneurological assessment, and then you move to the adjuncts. My perception, that was a heavy dose, so I stopped the lecture at this point. Remember, any trauma service is tailored based on your capacity, on what you have, and on what you can do. As you can see, there are a lot of variations. Remember, every trauma patient is a unique patient. The decision about that patient is made minute by minute based on the patient condition and what is suitable for the patient. I'm going to stop the talk here, and I'm willing to hear your thoughts. I'm willing to hear what you have, what sort of trauma you came across, if you have any challenging questions, if you have any scenarios we could discuss. This was only about acute care of trauma patient. The other component, which is operative management of trauma patient, or which is based on the American course, the ATOM, the Advanced Trauma Operative Management course. That's another aspect. What I just discussed is the tip of every component, and it's just a brain stimulation. Thank you very much.
Thank you very much, Mr. Ayman, for this very nice and enlightening presentation about acute management of trauma patient. Now, welcome everyone. Anyone have any question, please unmute yourself and ask your question.
Thank you, Mr. Ayman, for this nice presentation. I just want to ask about the evidence of permissive hypotension and how we can deal with it.
Ahmed, am I right?
Yes, yes.
Thank you very much, Ahmed, for the question. Permissive resuscitation is a concept that occurred because, as I said, trauma is a comprehensive service. You're not only looking to take the spleen of this patient, or you're not only looking to fix the fracture of this patient or that patient. You're looking at getting this patient back to their normal function as quick as you can. and to avoid morbidity and mortality. People have realized that not all patients should have a systolic blood pressure of 110 or 120. A patient with a traumatic dissecting aortic injury, we all know that there is an intima. The more you increase the systolic blood pressure, the more there's a shearing force in that intima, and it could actually result in a complete blockage of the aorta and you lose the patient. This is why you look for a blood pressure of 100. So it depends on the type of injury. As I said, if you have a pelvic hematoma, we know it's a venous bleeding. It will increase if we increase the blood pressure. If you have a concealed hematoma of the liver or the spleen, for example, if you have a grade 4 and 5 splenic or liver injury that we used to operate on them in the past, now it's not a golden rule. You could still go for conservative management. Here is where you use the permissive resuscitation, because you're looking for a clot to form, and this clot stays stable. And you're waiting for 24, 48 hours for this clot to become stable, and then you could start feeling free to give the anticoagulation for this patient, allow this patient to go for surgical procedures, and actually allow the blood pressure to go higher than 100. So permissive resuscitation could be used in certain circumstances.
Welcome, Dr. Fatma. Please, you can unmute yourself. Anyone have any question? I have question, Mr. about the right place for needle thoracotomy. Is it the second or the fifth intercostal space?
Okay, there are two practices for this. Yeah. تفضل يا حماد.
Steroid.
First question, let me answer the first question.
Regarding steroid.
Steroids type. First question, you're right. زي ما وريتكم احنا what we discussed today is just a conceptual approach to the primary severe, the ABCD approach. The needle, if it is a field practice, which means it's a pre-hospital team, or it is in military, you could go anywhere accessible in the chest. That's the rule, but you should not go below the 8 or 10 intercostal space because of the risk of going through the diaphragm. Okay, so in military, people have showed evidence that going anterior, mid-axillary is the same, as long as you could deflate the air in the pleural cavity. But the standard training is mid-clavicular line, second intercostal space. People think this is the safest area to go to, but you still need to have the standard or the newly developed now decompression needle. The second question about steroids, yes, there is definitely a confirm. For me as a trauma surgeon, I don't even wait for the neurosurgeon to decide. If I found on the pan-CT initially that there is hematoma in the spinal cord with neurological deficit, if I found that there is evidence of contusion to the spinal cord with neurological evidence, I immediately start a steroid, because minimizing the edema at that stage will actually decrease the chance of neurological deficit in the future. There is, again, a role in relation to traumatic brain injury, but the evidence is controversial. I wouldn't be the right person to talk about it. Normally, neurosurgeons are to be the right person to talk about it. But for me, even with my privilege, I have the privilege to prescribe steroids in that condition, for example. Again, if the patient has severe lung contusion with evidence of ARDS, but that's normally would be in discussion with the ICU. The only indication in acute phase is the spinal hematoma with evidence of contusion or compression on the spinal cord.
Mr. Hassan, you are welcome. Anyone have any question? Please unmute yourself and ask your question directly.
Good evening. everybody.
Salam.
I would like to ask if it is important to know if the patient is having, if the patient is having coagulopathy in early phase of resuscitation. Is it important to know that or not? And how does it affect the way of managing the patient? Especially in Sudan, we know that chasing result is time consuming sometimes.
Thank you very much for the question. Actually, yes, I'm still a regular visitor to Sudan, لكن the actual practice in trauma maybe أنا يعني not updated about it. So thanks very much for raising this issue. Number one, it's a fact يا دكتورة صفاء إنه any patient at the time of presentation of polytrauma patients, 33% of them having coagulopathy. بالايفيدنس 33% من التروما patients اللي بيجوا having coagulopathy. In our hospital, in our audit, the last 3 years, عندنا 25% of the trauma patients بيجوا بcoagulopathy. So they are coagulopathic from the start. It's interesting enough إنه average temperature عندنا للتروما patients اللي بيجونا is actually 36.5. So we're talking about hypothermia here. So we have hypothermia and we have 33% of the patient أو عندنا إحنا at least 26% عندهم coagulopathy. These patients are coagulopathic from the start. The average lactic acid اللي بيجينا for severe trauma اللي هو severity score of 15 and above is actually 2.8 initially, which means it's a high. عندهم acidosis. So potentially التروما patient اللي بيجونا هم hypothermic عندهم acidosis 33% منهم عندهم coagulopathy. So if we're not resuscitating them with fluid, if we're resuscitating them with fluid only, ما warm fluid, these patients are cold, ما أخذوا adequate tissue oxygenation, يبقى حتى اللي ما عنده coagulopathy, he's going to have a degree of coagulopathy. We're lucky إنه most of them are young, they have good capacity. Their baseline, they were normal until a sudden trauma occurred, drained everything, and they are still able to cope with it. So yes, investigate it. I think one initial sample is enough. If you ask me my opinion, what sample would you take? I would say send the lactic acid. Lactic acid is a very quick guide on tissue oxygenation. And take the temperature of this patient. Make sure you give blood and products rather than fluid. Come back in 12 hours, check the lactic acid. If the lactic acid is normal, don't go for any coagulation profile. Don't worry about it unless you're talking about an elderly patient, about a pregnant lady, or about a patient who's having high risk of coagulopathy. كويس لأنه coagulopathy will be corrected physiological. حتى الفactors احنا بنديها, even the factors you give, it's a transient response. So my advice with the lack of investigation, get your measure as the acidosis status of the patient. It is quick, it reflects your resuscitation. Make sure you're not giving fluid طوالي, you're giving blood after the first liter of fluid. يعني targeted resuscitation.
Okay, thank you very much.
You're welcome.
Prof. Sulaiman Hussein.
السلام عليكم أيمن.
وعليكم السلام والرحمة. كيف أخبارك وأحوالك؟
Thank you very much. I am very happy to see you back, and I think whatever we are saying about COVID-19, there is positive side of it. Otherwise, you won't see Ayman lecturing you from far away, and I think our registrars are lucky of having you. And this is a very good overview about trauma management in the acute setting. It is just a general comment, Ayman. We are trying our best to equip our hospitals, running trauma courses for juniors, but we are not doing much on the preventive side of management of trauma. Just like, and I think Bira and Magduda, roads badly constructed, what we call highways are not highways. We are licensing unsuitable cars for public transport, starting from rickshaw, going to Amjad, going to single door buses, and so on. And I do remember, if you remember back, I am not sure whether they were here, probably 2014. جمعية الجراحين looked at this carefully. وبتذكر عملنا مؤتمر addressing pattern of road traffic accident in تحدي رود شارع التحدي اللي هو لغاية عطبر. And that conference was held in Shindi. The issue was addressed by all the experts, muhandisin, police, politicians, trauma teams, and so on. And the conclusion, there were about 20 constructive deficiencies on the road. لو الناس المشوا بالطريق ده بيعرفوا إنه it is a very dangerous road to drive on. مزلقانات, not signposted, and so on. And since that time, nothing has happened to correct all those deficiencies. And you know what is happening in Medani Road and so on. So I think also part of us as professionals, I think we have to keep hammering on this. Regulations, people using I know that Ayman, what is the fine for somebody who's talking on his mobile when he's driving in Saudi Arabia? What is the fine for somebody who just crossed the red sign?
Light.
What is the fine for somebody who just knocked somebody on the pedestrian side? But here you can get away with everything. Okay. So I think the regulations and the policies, and I think that it is a team. You cannot ignore this at all. And bearing in mind our hospitals are badly equipped, there are deficiencies everywhere. So I think we have to work hard as professional bodies on the prevention side. We have to push the government to push the regulations. And without this, I think we will get nowhere. And the number of trauma victims, as you rightly said, exceed what I think now we are all horrified with COVID-19. But those who are dying on the streets of road traffic accidents is far more than those who are dying from COVID-19. But we are spending all the money on trying to prevent COVID-19 and ignoring the very killer, or if you just review the epidemiology of in Sudan now, I think road traffic accidents is high on the list now. So I know it is very painful saying all this. I'm not discouraging our juniors just to keep learning, to keep implementing what you have said, but I think we are in the professional bodies have got a job to do with the policymakers. I enjoyed your talk, Ayman, and we hope to see the next part of the talk about specific management. And I think I'm sure that our registrars are looking forward for the next part of your talk sometimes in this session. Thank you very much, Ayman, and we hope to see you shortly soon. Assalamu alaikum.
Thank you very much, Mr. I really appreciate your comment. And it was great pleasure to talk to you, Haqiqatan. It brought back all the memories, traveling to Medani and Shandi for the exams and this and that. It's really great to get to talk to you again. You've touched the core of the problem, and this is why I put the first part of the session. يمكن registrars who are going to take the exam now, they would say, okay, well, I would like to know, if you need trauma patient, how am I going to operate and do this and that? But I wanted to make it very clear, and people have to understand this, policymakers, hospital administrators, and even training bodies, that trauma care is not in the ER. I'm sorry, I know it's painful to say this, but you cannot have someone who's recklessly driving without a seat belt, يجي ER in a very bad condition, and then you lose him because simply it was too late to save this patient. And then the family start attacking the doctors, and that's a long story. So trauma care is not in the emergency room. Trauma care is a full comprehensive system. The hospital part is actually the fixing part. But the trauma care has to be a system from the start. انت بنفسك قلت طريقة تحدي 20 mistakes or 20 observations on the engineering of that road. Nothing happened. Nothing will happen. As you said, COVID-19. The funny thing is that, yes, trauma is still the number one, but what people can see or tend to forget that this is happening every year, and it will continue to happen every year. Maybe we do not, hopefully we do not see the same number of deaths of COVID-19 by the end of this year or early next year, but trauma mortality will continue to be there. enforcement of the law is the cornerstone. You cannot ask people, you cannot just get a trauma patient who's having all kinds of injuries and just leave him with the surgeon, with the anesthetist walking away and with the ICU walking away, and you don't have any support. This is why I insisted when I spoke today about the acute trauma care. I'm sure كل واحد من الشباب there know how to put a chest tube and know how to splint a fracture and know how to listen and relieve attention pneumothorax. That's not the issue. But you're fighting alone there. Unless you know the physiology and you know how to argue with ICU people and how to argue with the blood bank and with intervention radiologists and this and that, you're not going to get your patient right. And people will come and attack you. لأنه أنت اللي قتلت العيان. Yes, it's a complete system. Our role in my vision is the following. I still think that you start where you are and you improve yourself. I've worked on my training because my training originally was in trauma. I've worked on myself and on my training to have the insight and the understanding that not every trauma patient will take into theater. And the trauma patient who's having حبة blood تحت التable is just a small amount of blood, is not a large amount of blood. So it takes a big mindset. الحاجة الثانية, it takes ourselves to be able to look at this patient with all the help we can, speak within teams, work with teams. You know, احنا تعلمنا Mr. منك نفسين when I came to Sudan, منكم إنه you operate together as two surgeons. None of them is lack of skill or experience or so, but it's always good to have an extra pair of eyes. So you need a team with you. That's a parallel issue, but we've trained people. Some of the people I could see the names who are attending here are actually course directors in the trauma courses that we do. And we had at some stage even trauma team activation في السلاح الطبي مستشفى الطوارئ. But it did not continue. And the thing is that things do not continue because you're fighting alone. Either you give up or you get exhausted. I'm sorry, maybe this is not part of the expected exam, but it's you cannot have a discussion about trauma in Sudan without having all the pain popping up. Yes, it's a comprehensive service by a system. Thank you very much, Mr. Selima.
Thank you very much, Ayman. And I'm talking about this for our juniors. I'm not worried about the exam. I am worried about that you are going to be the health planners and leader of the future in this country. I am sure you're going to pass the exam with the amount of knowledge you have, but you will be the consultants of tomorrow. You will be the hospital administrator of tomorrow. You will be the policy makers of tomorrow. So as Ayman said, it's not a matter of how to put a chest tube. If there is a way of preventing somebody to come to have a chest tube, this would be better. I think that there is a lot of the responsibilities. I think that what we need to do is that we need a consultant who is a leader, who is an administrator, who is a trainer. His look is beyond the patient, usually the holistic approach to how it happened, where it happened, and why it happened, and how can we prevent it happening. And I think this should be the message for the junior staff. Yeah, and we shouldn't be just exam oriented, that I want to attend Ayman's lecture because I want to pass the exam. No. And I think that you are attending this lecture to have a good, what Ayman had been put as a holistic approach to look at the problem. And this is not for the trauma patient, but this should be for medicine in general. That the holistic approach, I think, is the way forward. I think that to solve the problems rather than the individualized medicine for each patient. Thank you very much, Ayman. And I'm still, and we are very demanding, and we hope to see you more and more. I think there is something not yet said about the next chapter of this problem, and I think as the organizers, just to, you don't need a lot of persuasion. I think this is part of what I know you are keen to do it. So hopefully we'll see you in a couple of presentations, Ayman, in trauma patients and probably beyond trauma, inshallah.
Thank you very much, Mr. Suleiman. Definitely, I kind of agreement to do a second session about operative management based on the ATOM course. It has a standardized way of care. I'll be happy to plan this مع Dr. Muhammad if they have still the time or the window for this. And I really would like the input of the registrars because زي ما قلت فعلا يا مستر إنه هم اللي they have to have the clear insight. We would like to hear what's their opinion, what's their insight لأنه they are going to take the lead very shortly إن شاء الله.
شكرا جزيلا بروف سليمان على المداخلة. شكرا جزيلا مستر أيمن على الكلام الغيم. we hope إنه زي ما بقولوا نستمع للجزء الثاني قريب إن شاء الله. شكرا جزيلا ونشوفك في الجزء الثاني إن شاء الله يا مستر.
شكرا جزيلا لكم. Thanks for your time and I hope to see you. السلام عليكم.